intervene a little bit inside the nervous tissue. So our daily current practice involves decompressing the spinal cord, stabilizing the spine, trying to prevent the complications, and then the patients are usually transmitted to rehabilitation centers in which they attain variable levels of improvement, but usually at the suboptimal level. So what could be done in order to change this situation? We all know that there is a primary spinal cord injury for which nothing can be done, but then the secondary cascade of events takes place, and each of these separate procedures is a target for a pharmaceutical intervention. But we can organize all these secondary cascades into three main directions. So the first one, these are the 3 R's from the literature. So neuroprotection is the first, to prevent lesion extension. The second one is to reconnect the damaged tracts. And the third is to take advantage of the intact tracts in order to gain the mobility and the sensitivity. So the first one is the neuroprotection, which entails all methods aiming at preventing lesion expansion. Despite compelling evidence from the literature, it took us a while in order to understand that we should operate as soon as possible. We all know that a few years before, all surgeons were reluctant to operate on an emergent basis, but finally this seminal paper came out and convinced us that we should try to operate as soon as possible, but the debate goes on. Now there is a huge discussion concerning if ultra early surgery should be done. Should we operate during the night, or maybe should we leave it for the next morning? So there are a few publications which recommend ultra early intervention. On the other hand, we had this European multi-center UK-based study which did not really show any big difference, but we are waiting several later studies. Concerning duroplasty, it can complement our surgical operation. It has the same rationale with cranioplasty, so with decompressive craniectomy, that we should give space to the edematous spinal cord. Everybody fears the complications with the leak of cerebrospinal fluid, but it seems that there are nice publications now recommending this technique. For hypothermia, the recommendations are more vague. It can be applied systemically or locally. There is no optimal target temperature, but usually most researchers aim for 33 degrees Celsius. And there is this prospective multicenter study aiming to delineate these indications. When we're talking about the neuroprotection, of course, the major component are drugs, and we are all aware of these old studies with methylprednisolone and tirilazate and GM1 ganglioside, which now are considered obsolete. But we learned in 2014 that inflammation in spinal cord rests forever. It never subsides. So we have a lot of strategies concerning the immunology part of the injury. So we use now antioxidants, immunosuppressants, immunomodulatory peptides, and glial scar inhibitors in order to mediate this kind of response, this cystic cavity that forms after the injury. These are the newer neuroprotective agents. We have a lot of immunological drugs like elezanumab and edavarone, but unfortunately, none of those has gained any admission from the great pharmaceutical societies because there is no result yet. The second direction, which is the most challenging, is the rewiring. This means to restore the damaged spinal cord tracts. And there are several ways to rewire the tracts, like regeneration, collateral sprouting, the bypass of the lesion, to take advantage of the unilateral connections, or the remodeling of the cortex. These three are obvious, but I'm going to analyze the first two. So when we're talking about axon regeneration, it's a procedure which includes the following processes. So the cell body needs to react, then the axon is elongated, and then there is the routing to the target, and then we have the synaptogenesis, and finally the axon has to be myelinated. All this, and not just the elongation of the axon, is the regeneration. Unfortunately, there is no regeneration in human central nervous system. It only happens in the peripheral nervous system. We all know this procedure of Wallerian degeneration and then the restoration of the connection. But in the central nervous system, we have a lot of molecules which are inhibitory. So practically, there is no regeneration. Another mechanism, which is usually confused with regeneration, is sprouting. Sprouting is the development of collateral branches, either from intact neuractions or from damaged neuractions, but it's not really regeneration. Regeneration should be done in this way, and it does not take place. Sprouting happens in humans, but it's implicated in the development of spasticity. Another method would be to achieve growth induction. We can either insert a scaffolding inside the spinal cord, place supporting cells, either Schwann cells or oligodendrocytes, provide growth factors, or render the extracellular matrix permissive to regeneration. The other way would be to suspend the inhibition. So to neutralize all these myelin-associated molecules like NOGO-A, or to face the scar-related problems with several enzymes such as chondroitinase, or to target all these guidance cues which are induced after the injury. Each of these can be a drug target. And finally, we can aim at several inflammatory biomarkers which are released. A molecule that has gained a lot of interest is this ROA. It's a small GTPase, and it's responsible for the development of growth cones. And this molecule inhibits the growth cones. So if we inhibit the molecule, then maybe the neuraction will be in a developmental mode. So there was an enthusiasm with Cethrin. It was a drug which was developed in order to attack this ROA molecule. And initially, there were some encouraging results, but finally, most studies were either withdrawn or suspended. Now this ROA has regained interest, and we have new inhibitors, but unfortunately there were no results with these attempts. So the mainstay for regeneration and for rewiring the tracts are the cellular therapies. But we do not place the cells in order to replace the neural cells that have been destroyed. That would be overambitious. These cell replacements have indirect roles, so they provide a permissive environment for the neuractions. They can achieve relay connections with the neurons that are inside. Several neuroprotective or growth factors may be produced. And finally, there is neovascularization, which helps in the restoration of spinal cord injury. These are the cell types that have been applied. The first one were the Schwann cells, the cells that are responsible for this differential behavior of the peripheral towards the central nervous system concerning regeneration. There are a lot of studies, but the results are rather mediocre. In some cases, they seem to have a statistical significance, but generally there wasn't much effect. So the next cellular type were the mesenchymal stem cells. These can be obtained from various sources: the bone marrow, fat, the umbilical cord, the periosteum. There is no need for immunosuppression. It's very easy to isolate these cells even during the operating time, and then to insert these cells inside the cavity. They produce neurotrophins. They have an anti-inflammatory effect, but it's highly disputed if they can be differentiated into neurons. You can see various studies with these mesenchymal bone marrow stromal cells with various routes of administrations. It seems that it's safe to use them, but there is no study having shown that there is a clear improvement in patients. And of course, there is this risk of tumorigenicity, which has been highlighted by Evan Snyder in this commentary. And in the future, we will see several combinations of Schwann cells and bone marrow stromal cells. These are genetically engineered cells which have advantages of both categories. The only new nervous cell which has the potential of multiplicating in the central nervous system is the olfactory sheathing cell, and these have been used in transplantations. Again, they are very easy to obtain. You have the ENT surgeon removing these cells from the roof of the nose, and then there is a special procedure to isolate them and make them ready for transplantation during the operation. So there are a lot of these attempts. The problem is that several teratomas were developed, and this is something very distressing. So our colleagues in Poland, in Warsaw, made another attempt. So they performed a mini supraorbital craniotomy, and they got the olfactory bulb, which is a clear nervous tissue, devoid of epithelial cells, and they transplanted this olfactory bulb in patients with spinal cord injury. Of course, it's something which is very invasive, and there were a lot of comments, but the research goes on. But no results have been published yet from their larger series. But from the biological point of view, the embryonic stem cells are the mainstay of treatment, the best cells to use. We all know that Barack Obama first signed this big trial in the US, which was finally halted because the company went bankrupt. But there was a revival of this study last year, and several of the researchers which initially participated declared that finally the study was safe and a few patients had improved. Adult neural stem cells are another option. There are a lot of studies, but no results. And probably the best candidate will be the induced pluripotent cells. These are differentiated cells that via the Tamanaka work, a standard protocol, can be reprogrammed to become immature cells and develop into all tissues. We can take these cells from a lot of sources. There is no need for immunosuppression because they belong to the same human, but they have a lot of disadvantages. You need a lot of time to prepare them for a transplantation, but the technology bypasses all obstacles, and we are going to see them in the near future, maybe in combination with scaffoldings. I would like to highlight the importance of exosomes. There is no application in humans, but in the laboratory animals, it's something that has a huge development. There are secretory organelles which contain miRNA and siRNA, and they confer messages to other parts of the nervous system. And there are a lot of papers in combination with bone marrow stroma cells taking advantage of these vesicles. What we will see in the future are combinatorial techniques. You can see here that we will probably resect the spinal cord injury scar using neuromonitoring, and then maybe we're going to insert a scaffolding with several types of cells and neurotrophins or drug cocktails in order to promote the regeneration. Problems to consider is the timing of transplantation, how many trials, the tumorigenicity and immunogenicity, and of course we should always take into consideration that a lot of humans present spontaneous recovery, so it's difficult to compare the different methods. The third direction is the reactivation. This is not actually a part of my presentation, but it's the only direction that actually works. So I would like to have a few comments. So we now know that in our lumbar spine, maybe at the level T12 to L1 in the cone, there is this central pattern generator, an intrinsic spinal circuit for movement. And this circuit has been exploited by a serendipitous finding. They were playing actually with a stimulator and the patient began to move. And then there was a lot of research concerning this epidural stimulation. And this is a European study. This is a wonderful scientific story from basic science to clinical applications. So in Lausanne, they found in the laboratory animals that a special combination of stimulation provokes movement. And then this STIMO research appeared with our colleague Jocelyn Bloch. And now they have this publication for the results, and now this STIMO is combined with brain control interface for better results. We do not know how this generator works, but there are several speculations. Exoskeletons are continuously applied. I would like to close this presentation with this remark. You should have critical thinking. So it's very easy to find, for example, this study, which seems very important, intraspinal transplantation of human central nervous system stem cells. The centers are very serious, but when you come to find the results, there is no site, and there are no results and no publication. The majority of research of clinical trials belong to this category. So we need to decompress our patients early. There are no drugs available. There are several cellular therapies for neuroregeneration without a clear advantage. At present, only reactivation and rehabilitation improves the patients. We need combination of techniques, and we definitely need research protocols and no improvisation. So the way is long, but I think that it will be rewarding. Thank you very much for your attention.
Thank you very much, Professor Chadzisotiriou. It's a very particular, a very specific topic, but we neurosurgeons must be aware of these things, because more and more in the future, we will have to deal with such issues. Any questions from the audience?
I do have a question.
Yes, Professor.
Because the two new techniques, or pretty new techniques that deserve probably discussion, because we all know that we need to decompress, to restabilize and realign the spine. Okay, what we did already more than 50 years ago. But I'd like to know which is the advice of the panel and the expert about the duroplasty, and another point is lumbar drainage. There is a literature extrapolated by cardiac surgery, cardiovascular surgery, where putting a drainage might release the pressure on the spinal cord injury during these procedures. And I don't know if Andreas or the others, you implement the duroplasty and or lumbar drainage for acute spinal cord injury.
Andreas.
So I think the thing to admit is that this is not standard treatment, but it's available via a trial. The trial is called DISCUS, and DISCUS is basically a trial where only cervical spinal cord injury is randomized in two groups. Group one is decompression and fixation, and the other one is decompression and fixation plus duroplasty. We are a participating center, yes, to the DISCUS trial. You showed the authors. It's worth mentioning that the two people behind the DISCUS is Samira Saadoun, who is married to Marios Papadopoulos from London. It's a difficult trial, really, because of ethics, and also because of the low incidence of spinal cord injury in the cervical spine. And I think the jury is out as to whether it will make a difference or not. So the answer is not routinely, but only as part of a trial, we would do the duroplasty.
Thank you.
Anasi, you want to comment on that?
No, it's just a matter of research, but I think that it has the rationale. I mean, the spinal cord is edematous. There is this inflammation does not subside, so I think why not? It's the same tissue. So apart from fearing the complications of infection, I think that duroplasty should be a viable option. I mean, from the pathophysiological part of view, yes, we should provide space.
Thank you.